All right. Hi, everybody. I'm so excited to welcome Dr. Sachdev to the podcast today. Dr. Sachdev is a distinguished and highly sought after fertility specialist, a double board certified expert in reproductive endocrinology and infertility, as well as obstetrics and gynecology. With advanced training from renowned institutions, including NYU and the University of Chicago, Dr. Sachdev brings unparalleled expertise and a compassionate approach to her patients' journeys toward parenthood. Known for her friendly and calming demeanor, Dr. Sachdev's patients comment on her ability to break down complex topics into easily digestible concepts, making the fertility journey seem much less daunting and intimidating. I am so excited for you to join me on my podcast today. And, I was trying to think about how many years we've worked together, and I was thinking like five,
No,
4, and
uh,
maybe you have a better
yeah,
recollection than I
it'll be
do.
8 years this September that I've been
Oh
practicing
my
in Orange
goodness.
County.
Wow. And
Yeah,
and tell us a little bit about your practice. Where are you located? Where are you
yeah.
practicing out of?
So I was I was been in Orange County for 8 years. I was in Newport Beach for a long time, and then in 2025, relocated to Aliso Viejo and started to practice with two other great REI physicians. And our practice is here in Aliso Viejo, California, so South Orange County. And our practice name is South Coast Fertility Specialists.
I love what you guys have developed, and I had the privilege of touring your place a couple months ago, and I'm really impressed by the facility and so excited about the embryology lab you guys will be developing. And so what has that been like for all of you?
It's
Taking
been,
on a project like that. I mean, that's a
yeah.
huge project.
It is a huge, it's definitely an understatement. It's been awesome. I mean, because one, we are really getting to decide what's important to us, what matters to us, and learning about things that, although yes, we've been doing this for a long time, but figuring out, okay, what are the different air filtration systems, and why does one person choose one versus the other, and what are the pros and cons, and how does that affect the lab infrastructure? And then, we get to choose, all right, what kind of incubators do we want to have?
Yeah.
What kind of gases do we want? Do we want the ones that are pre-mixed or the ones you have to mix? And what are the pros and cons? So it has really been really awesome to learn all those things that you learn about when being trained, but really
hmm
need to have a very good understanding of. Um,
But what an opportunity to be able to handpick everything in
yes.
your lab, in your clinic, like technology wise, and just incorporate like the best versions of everything. I kind of think of it as like if you built a house from scratch versus moving into a house that's nice, but already constructed and, already had an interior designer you know, kind of judge it up a little bit. And here you're like, okay, let me put my flair on it. Let me customize it to my liking. But here you guys get to build it from ground up and just have everything you ever wanted in an IVF center. So I think that's just so cool.
I mean, it's awesome. It's awesome. And so, yeah, we started the process. Construction's underway. So hopefully,
Nice.
20,
What's the delivery date or the
that's
opening
hard to
date?
say. I think our contractor's given us some dates, but
Mhm.
you know, I can't say for sure. But
Yes.
2026 is
2026.
is
Okay.
yeah,
Can't wait. We're gonna
yeah.
have to celebrate.
Oh yes, definitely. We're already planning our celebration.
Awesome. Well, let's dial back a little bit. I wanted to just kind of ask you a little bit about your background and what got you started in your specialty as a reproductive endocrinologist and infertility specialist. Like, how
Yeah,
did the journey begin for you?
totally. Um, So I went into OBGYN because I really like the idea of caring for a pregnant patient. I thought it was fascinating how Mother Nature has designed the system, how we can literally grow a human in our bodies. And so I was really just kind of infatuated with that. And then when I was in residency as an intern, as an intern, you spend the kind of the most time with the patient. So when they're in labor and about to have their babies, you're typically the ones that are in there with them, pushing and spending a long time with them. So it was in my intern year that I really spent a lot of time delivering babies. And what really piqued my interest was when I would help deliver the babies of women who'd gone through infertility.
Mm-hmm.
And just hearing them talk about how they got pregnant, what they had to do to get pregnant. And kind of a light bulb went off. And I was like, wow, I mean, it's just so beautiful to deliver a baby, but there are people who wouldn't be able to get here if it wasn't for certain doctors. And that's when I realized I wasn't just the idea of helping, like of caring for somebody while they were pregnant. It was the
Sure.
idea that I could literally do something that changed their lives. And that is what really first got me interested in it. And then I learned more about it and I realized like how much cooler can it get? That,
Yeah.
like when you think about science and technology, this is it.
Hmm.
And then I just, fell in love with the whole package.
Yeah. What did that look like for you in terms of your training? So you're going in, finishing up your specialty in obstetrics and gynecology, and what's involved when you're, sort of extending your specialty into fertility or
Well,
infertility?
with any specialty, you have to show a demonstrated interest in it beforehand. So in
Mm.
residency, we would, I would then spend time doing research
Hmm.
in reproductive endocrinology and infertility. So, beyond your however many work week, you then in the evening spend time learning about it and working with the
Wow.
providers.
In your free time, right?
Yeah, in your free time. But when it's so interesting, it's less burdensome and more like a privilege. And I
Right.
was so
Right.
lucky that I, had mentors that were these amazing fertility specialists and really in not just fertility, but in very different things. I had Mary Stevenson was my mentor, and she's a recurrent pregnancy loss expert. So really, she didn't focus on IVF at all. She focused
Hmm.
on diagnosing and how to treat and all these different things and how to help women with recurrent pregnancy loss.
Hmm.
And then, I also had other mentors like Eve Feinberg, who does so much at ASRM and, in the realm of education. And she taught me what it was like to be, somebody who was still involved in academics and teaching and private practice and what it was really like to be someone. And I would be able to watch her talk to patients and see how she would advocate for them in their consultation.
Hmm.
And she really taught me how to approach caring for patients much far beyond, okay, this is what you need to do or what you have to do, but more like this is what you can do. And together, let's figure out what you should do.
Right.
Um,
Right. Yeah,
and
that
then,
sounds like a very comprehensive approach and just being really, you know, uh, keen into kind of like connecting with your patients at a deeper level.
yeah. And it's, every person's path takes them to unique things. But what was really interesting is that at the University of Chicago, we had a lot of patients that came internationally to do something called pre-implantation genetic diagnosis.
Uh-huh.
I think that they worked with, like international countries, because in certain parts of the world, um, rare genetic disorders are just a little bit more prevalent based upon
Hmm.
how they choose their spouses. And so, I got to experience that. And that was something that just was even more fascinating to say, wait, we can then take embryos and identify which have this potentially debilitating genetic disorder and
Hmm.
then help these families have children without them.
Right.
So it just
That's
felt,
so, I mean, medicine's just so incredible and ever evolving, and the opportunities that, parents to be have now compared to even 5 years ago.
yeah. Yeah,
Yeah.
I mean, when I was in residency, egg freezing was still experimental. And I
Hmm.
remember watching, my mentors having conversations with patients about how, well, that's still experimental. And then
Right.
fast
Right.
forward to, when I did fellowship at NYU, it was 2014 to 2017. I mean, a third of all cycles were egg freezing. Uh,
Right.
right. And
Yeah.
so,
It seems like such a long time ago that patients were transferring fresh day three embryos,
yes.
but really actually not that long ago.
Oh,
But when you really look at just like the actual dates, because I don't want to date myself, but I've been in practice for about 24 years. So when I started, it was all fresh day three embryos, multiple embryos being transferred at a time, and lots of twins, some
yes.
triplets. It was like a whole different era. And now, I mean, I rarely see anybody that's transferring more than one embryo.
Yeah.
Yeah.
Because,
Would you be able to share a little bit, Dr. Sasha, for those patients that are not quite familiar with the IVF process and genetic testing, or maybe they're just starting off on their IVF journey, would you be able to talk a little bit about PGT testing and genetic testing and the options that are available?
yeah, totally. So I think the best way to help explain it is to kind of, as a background, to understand that, every person comes from an egg and a sperm. We often call them mom and dad, but it's an egg and a sperm, and we get half of our DNA from that egg and that sperm. Typically, we'll get 23 and 23 to equal 46.
Hmm.
So if the egg and the sperm have half the DNA, well, that means that since we all have 46, there has to be a division that occurs. for both egg and sperm.
Right.
Because men are making sperm every 90 days.
Mm-hmm.
That mechanism is fairly well maintained. Even if somebody is 60 years old, the sperm that they're producing is actually only 90 days old. So when that sperm goes to divide, it happens pretty well. So the sperm typically will have exactly what they need, 23 chromosomes. But for women, our eggs we're born with all the eggs that we have. And as we're getting older and we have less eggs, our eggs are the same age as us. So if I have a patient who's 30 years old versus 40 years old, somebody has 30-year-old eggs versus 40-year-old eggs.
Right.
When we go to ovulate, whether that's naturally or during treatment, during the ovulation process is when the division occurs to say, okay, we need exactly 23 chromosomes. And so the longer those eggs have been in our body waiting to complete that, the more likely they are to make a mistake in that. So if somebody is 30 versus 40, the 30-year-old eggs, regardless of the number, are more likely to have the appropriate chromosomes than the 40-year-old. When the sperm comes swimming along, 90% of the sperm are going to have the appropriate chromosomes. But ultimately, if they fertilize and go to make an embryo, we don't know if that embryo has the appropriate chromosomes, 46XX or 46XY, or if it has an additional chromosome or is missing a chromosome. So we have the ability to say, all right, let's take out a few cells from this embryo, which is made up of hundreds of cells, to say, okay, if we take out a few cells, which should represent the entire embryo, can we determine what the genetic makeup is of that embryo? And that's what pre-implantation genetic testing is. And so there's different things that you can test for, but the most common one is called PGT-A, which is looking for aneuploidy, the number of chromosomes. So they take out a few cells and they take the DNA from there and they amplify it. And then they can identify, okay, this embryo actually has 47 chromosomes. It has, 2 copies of everything, but it has 3 copies of chromosome 16. And then embryo 2, this one has exactly 46 chromosomes. It has 2 copies of everything, including the X's 46XX. And so I always tell patients, by testing the embryos, I'm not doing anything to fix the embryo or to make it better. It's like I have cards that I'm flipping over. And so I'm saying, okay, I have embryo 1, 2, 3, and 4, and I'm flipping them over to say, okay, embryos 1 and 4 are chromosomally normal, 2 and 3 are chromosomally abnormal. So the subsequent cycle in the next month, we're going to focus on transferring either embryo 1 or 4.
Right, right.
The byproduct of that is that you can find out the gender if you choose to. So when patients say they want to balance their family, this is the way that we do it. But the main reason why we do it is because those other embryos that are chromosomally abnormal are not likely to lead to a live birth, or they're likely to lead to, a miscarriage or a negative pregnancy test. So the goal is to say, all right, can we identify which ones we need to focus on?
Yeah, and it's always so promising when patients have options, right? And they have multiple embryos that are euploid that they're able to transfer. So what happens if a patient comes back with embryos that are maybe they don't have any normal embryos? What's usually the recommendation?
So, I mean, it depends on a lot of things. It depends on their age. It depends on the number of, eggs we retrieved and their ovarian reserve. But I like an IVF into having a jar full of marbles, okay? And imagine the marbles are the eggs that we have in our ovaries. So the number of eggs in that jar is related to our ovarian reserve, right? The greater our ovarian reserve, the more marbles in the jar.
Right.
The percentage of those marbles that are quote unquote going to lead to a normal embryo depended upon our age. And when we do IVF, we're putting our hand into that jar and picking out some marbles. Now, the size of our hand often is proportionate to the number of marbles.
Sure.
Right. But so when we go in and we pick them out, it kind of is blindly, right? Although, yes, in the procedure, you can tell what you're doing, but you can't, the egg is microscopic.
Right, right.
So we're kind of blindly going in and picking them out. And if we don't find any good ones, that gets dumped out. We get a new jar of marbles and then we try again. So,
that's a great analogy because, like you said, sometimes you're going into these egg retrievals and maybe initially your antral follicle count was looking like maybe 5, and maybe you might actually have a few extra, which is always bonus and always great. Or maybe sometimes it's actually less and some of them were not viable eggs to be retrieved. So,
but that's the hard part, is that every month we get a new crop of eggs.
And
so it's not like if you have eggs that all led to abnormal embryos, that's a representation of everything. It's a representation of that month.
Right,
And
right.
so that's what I tell patients is that, and there are some patients who, due to circumstance or by choice, they just haven't tried to get pregnant.
Hmm.
I said, IVF for everybody gives you a greater chance of getting pregnant. However, it's really a snapshot at 1 month.
Yes.
So when people try to
Yeah.
get pregnant and they try January, February, March, why is it that March they got pregnant and not January, February?
Yeah.
Right. And so that's what IVF is, which is hard to hear because it's it's challenging for some people physically and mentally, and for some people
Hmm.
financially burdensome.
Sure.
But that is why people end up having to do more than one cycle.
Right, right. Well, that makes a lot of sense. And I think when you explain it that way, it's easier to wrap your head around it and accept, that you may have to do multiple cycles and that each cycle is like unique, right?
Yeah. I mean, I've had patients where they did one cycle and I think a lot of people think it's only a numbers game. Numbers matter, right? And numbers help when talking about statistics, but there's a lot that's somewhat up to chance because we can't, again, the egg is microscopic. When we go in to get it, when we're doing ultrasounds, we can't see the quality of the egg until we take it out.
Right.
So
Right.
I've had patients who had a lot of embryos and not anything that was normal, and then they made embryos, maybe a smaller number, but then they did have some normal embryos. So
Hmm.
it's even harder. I mean, it's comparison is human nature. Somebody can have friends who did it, and they're often like, my
Yeah.
friend had X, Y, and Z.
Right,
But it's
right.
even worse. I tell patients, like, it's even worse when you try to compare yourself to yourself,
Exactly. And
right?
it's hard not to hold on to history because
Yeah.
that's what we do.
Yeah. I mean, that's human nature. We're all humans here.
Right, right.
And
And we
so,
are oftentimes very connected and linked to our memories of
yes.
past situations. But
Yeah.
but I like how you said it because it's sort of like think of it as a new fresh start
Mhm.
each cycle.
Yeah.
And who wouldn't want that? Like a new opportunity to get
Yeah.
hopefully a healthier, optimal batch of embryos, several.
Yeah. That's the
So,
goal.
so going back to so we're talking about embryos, but I'm curious to know a little bit more about egg freezing. So I know, since I know that's one of your ex areas of expertise is egg freezing for women that maybe haven't found their partner yet, or they're just, trying to kind of prepare for future. It's like an
Yeah.
insurance policy for becoming a mom. What
Yeah.
does that look like now? Egg freezing has changed so much, even in like the last 5 to 10 years.
Yeah. So, I mean, that's you bring up like so many good points. So, yeah. So, egg freezing, I think just the way that people view egg freezing is very different now than it was 5 to 10 years ago. I think people used to think of egg freezing as a last resort.
Hmm.
But really, like, I think reframing it, egg freezing is just a way to give you options, right? And like you said
Yeah,
earlier, who doesn't want options, right?
totally.
It's
That's
kind of
true.
like, when you're in college, right? Maybe you choose a major that is going to give you an opportunity to have maybe different career paths,
Hmm.
right? And that's kind of how I think of it. Um, and many people initially used to refer to it as an insurance. And I like to reframe that as well, because anybody who's had insurance knows that insurance may or may not pay for all of it, or it might pay for some of it. But
Right.
unfortunately, I can't give anybody part of a baby, right?
Okay, yes, please school me in this.
I
It's
can't give
not an
anybody
insurance
part of a baby. I
policy.
can't give you partial. And nobody wants partial. They want
Right.
all or nothing. So
Yes,
I
that's
really, I
right.
think of egg freezing more as an investment. Right.
Okay.
And
Yeah.
so, and so when we're talking about it, the younger you are and the more eggs you have, the more likely you are to get a return on that investment.
Hmm.
And
Hmm.
that's really, when thinking about egg freezing is should I do it or should I not? It's about investing in yourself to give yourself the option. So
I
the
like that.
background for egg freezing is similar to what we talked about with egg quality and why we do PGT testing. But as we get older, when our eggs get released, they're more likely to have made mistakes in that process. And so
Hmm.
the older we are, the less likely we are to have eggs that are going to lead to viable embryos. And so
Can I ask you, you probably get this question a lot. Can I ask you, what is the ideal age range to freeze your eggs?
ideally is under 33. That's the ideal range, but not everyone's life is that linear. And so,
Hmm.
if I have somebody who's 36, 37 sitting here, do I say, hey, you shouldn't freeze your eggs? No, by no means do I say that. Um, so, it depends, but the key is that the younger we are, when we take those eggs out, the more likely they are to lead to the outcome that we want,
Right. Right.
right? And it's a balance for some people. Some people aren't financially in a position at 29 to
Yeah.
freeze their eggs, but they will be at 34,
Hmm. Hmm.
right? And so it's hard to say. And for a lot of people, I think that, they don't want to do freezer eggs if they think they're not going to use them, which I totally respect. But at the same time, you want to be able to make, you want to be able to make decisions about your own life and future based on what you want, not out of a concern for your reproductive health necessarily.
Right,
And
right.
again, it kind of goes back to what I said. Just because you froze your eggs doesn't mean that it will 100% lead to a baby,
Hmm.
right?
Hmm.
But women are in a very different place than men from a reproductive standpoint.
Absolutely.
And
And I think for women that are really invested in their education and their careers, it's definitely something to consider because, we're pushing ourselves so hard to like finish multiple degrees, start businesses, or enter into the workplace. And, there's just like so many amazing, strong, empowered women out there, a bunch of boss ladies out there. And,
yeah, yeah. I actually had this conversation with somebody at my son's soccer practice, just saying
Mhm.
they were
I love it.
and they were an older parent, and
Uh-huh.
they were like,
Yeah.
I'm thankful that I had the opportunity to be a parent once I was older and more established in my career, because now I'm able to pick them up and take them to soccer practice and all these different
Mhm.
things. Whereas if I was younger in my career, it would be really challenging. I would feel like I would have to be making a choice.
Yes.
And so,
Yeah. And you don't have as much time to dedicate to be as present for your children because
yeah, and
running around and yeah, for sure.
exactly. And people are in a better financial situation where they can, having children is not inexpensive. So, so there's a multitude of reasons why people would choose to build their family in their own timeline, right?
Hmm.
So, but going back to it, that's why egg freezing is such a valuable asset that we now have. Is that, yeah, I tell patients in an ideal situation, you freeze your eggs and you feel the freedom to make decisions based on your own timeline. And in the best of situations, when you call me and say, hey, Dr. Sachdev, I'm ready to get pregnant, I'm going to say, great, try, and you conceive, right? And you never have to use these eggs,
Sure.
right?
Yeah.
And
That is
so
ideal.
that's the
For
ideal
sure.
situation, right?
Yeah,
But like another
definitely.
situation is maybe you conceive, but then now, let's say you have two kids and you're like, okay, I didn't need those eggs, but then now
Mhm.
you're 44 and you're like, hey, I would really love a third.
Yeah, that
You have your
happens.
frozen eggs,
Hmm. Hmm.
right? Like, and so it just gives you flexibility. It gives you options. And yes, there's a possibility that people could freeze their eggs and not have to use it. But really, I mean, freedom is a luxury.
For sure. I have so many questions that are just racing through my head about egg freezing. Um, Out of curiosity, what is the time frame or what is the ideal time frame that you should, if you're going to kind of tap into your frozen egg reserve, when's the best time to do it? Like within 10 years,
Yeah.
within five? I'm always
Oh,
curious about that. Like,
so, okay. So it has nothing to do with the length of time the eggs are frozen. I'm not concerned that somebody froze
mhm.
their eggs for 5 years or 10 years. What I am
Oh,
concerned about is how old they are when they come back to use those eggs.
I see. Okay.
Why?
So the age of
Because,
transfer.
well, not just the age of transfer. I'm honestly, the age of transfer, yes, we want to make sure they're healthy and things of that sort,
Hmm.
but I'm not
Hmm.
super concerned about somebody being 38 and getting pregnant. I'm more so concerned if somebody freezes their eggs at 35 and then they come back at 42. And if for some reason those eggs didn't lead to a live birth, or it led to one embryo but they want multiple kids, now we're having to work with 42-year-old eggs versus your own
Yes.
35-year-old eggs,
Right. Right.
right?
Hmm.
And so that's a part of it. And a lot of how I counsel patients is feedback from what I get from patients, right? I had a patient come to see me who was 43, who froze her eggs with a different provider. And she said, no one ever talked to me about when I should come back to use my eggs. And I just kind of magically thought these eggs would automatically give me a baby. And when they did
Sure.
it, now I'm 42, 43. She goes, I totally
Mm.
would have done it like, years
Right. Right.
beforehand. And so I think that's important. I'm less focused on the number of years than as opposed to how old you are when. If somebody hypothetically freezes at 25, I'm not concerned if they're not ready at 30 to use their eggs, right?
Sure.
But if somebody freezes at 35 and they're debating whether to come back and use their eggs at 38 versus wait until they're 40, I would say you want to at least thaw them and make embryos at 38 to see, okay, do I need to bank more for the future?
Yes. Yeah, that's a really good point.
And I have that conversation with people when talking about just eggs. They're like, should I bank more? And
Hmm.
and it
Hmm.
depends on the person, their age, and their ovarian reserve, and how many eggs we got, right? And so when they're younger, again, this goes back to flexibility and having options. When they're like 29, 30, I would say, hey, I think this might be an appropriate number. Let's see where your life takes you. And let's reevaluate in a year or 2 years. If you feel like you're in a place where you're getting closer to wanting to build a family, you're probably good. But if you feel like, you might still be several years out, then let's consider banking some more.
Sure. Yeah, that makes a lot of sense. There's so much thought that goes into this whole process beyond like, let's just freeze and then just we're done.
Well,
You
I
know,
well,
it's
I think that's my approach at least.
mhm.
I like to talk things out, to talk about, I always say, let's play best case, worst case. Right. And so we talk things out and to map it out, I mean, honestly, a consult could be 20 minutes if you wanted it to be, right? But that's the joy in what I do, is getting to talk to people, I kind of have a conversation, giving them things to think about, and then coming back and be like, okay, how do you feel about this or that? You know,
Yes, I love that. Yeah.
I have some patients who are married and they want to freeze eggs, and I have some patients who are not married and they want to make embryos. And we talk about, okay,
Hmm.
what are the pros and cons
Hmm.
of the
Hmm.
decision that you're making, and why would, what are the risk benefit analysis of doing each? So, it's not necessarily just like, oh, cool, you want to freeze your eggs? Let's freeze your eggs. Yes, we definitely can do that, but let's talk about what it means to make an embryo from your eggs, what it means to make an embryo from fresh eggs versus frozen, what this means for
Right.
you and your
Right.
life trajectory. So
Have you seen a trend, like a rise in the trend of people freezing their eggs, as well as like women that are kind of doing it on their own and deciding, like, hey, I'm ready to be a mom, even though I haven't found my partner in life?
yeah, I mean, I wouldn't necessarily call it a trend. I think it's just, I think society is changing. I think the
Mm,
benefits of social media, people are talking about things. And I think people are more open. Egg freezing, like I said, used to be like a last resort, like, oh, I
sure.
feel like you know, this is my last option versus, hey, I get to do this. So
Mhm.
yeah, egg freezing has definitely increased, and becoming a single mother by choice, I'm definitely seeing more often now. Um, and so I think all of it is just lending to the fact that we're more open about these things.
Yeah, that's incredible. I do love that whole landscape of like you have all these options now as a
Yeah.
woman, and
Yeah.
you can kind of decide. But I think thinking about it kind of more thoroughly is
Mhm.
so important, right? Because
Yeah.
knowing that at every phase of our life, things change for us, right? Our hormones change, our bodies change, all of it changes. So we have to kind of think ahead a little bit and decipher what's going to be the best plan and
Yeah.
best outlook for our journey into parenthood.
Totally. Especially like, egg freezing patients, I don't look at it as, oh, okay, you freeze your eggs and I never see you again until you're ready to get pregnant. I tell them, I'm like, let's check in a year. Let's see
Nice.
where things are, or like, hey, you are thinking about trying to get pregnant, let's call me, set up a time. I'll map you, when to have sex, how to track your cycles. So it's, yeah, it's like, think, people have like a college counselor, right?
Yes.
That's how I kind of view egg
An
freezing.
academic counselor, even beginning in high school, right? Yes. The
Yeah,
sooner the better, right?
yeah,
You
but
you mentioned earlier, Dr. Sachdev, in your training that one of your mentors did a lot of work around recurrent pregnancy loss. So we're seeing a lot of that in our practice. And I wanted to ask you some questions around that too, and what you're seeing for some of the conditions that might be leading to recurrent loss.
yeah, I mean, I think, the uh, a big part of recurrent pregnancy loss is that so much of it is unexplained.
Hmm.
And it's heartbreaking because people want to say, what is cause? Is it this, or this? And in a lot of cases, finding a cause doesn't necessarily make it any easier to overcome, because then you found that hurdle. Now we have to overcome that hurdle. What is that hurdle?
Sure.
Right? But a lot of the cases are still unexplained. Age causes some of it for the reasons we talked about, abnormal chromosomes. Um, Autoimmune issues
Yes.
are a big part of it as well. And especially because, some people don't have the classic autoimmune factors, right? But they probably have some component of it. And underlying health factors, people who have inflammatory bowel diseases, or, even
Mhm.
like a psoriasis and rheumatoid arthritis, those are all autoimmune disorders, type 1
Right.
diabetes that can play and interfere in how people, are getting pregnant, and the risks of miscarriage. So I think everything, plus there probably are environmental factors that we are slowly starting to identify, but it's hard to
Hmm.
say, oh, is it exactly X, Y, or Z?
Sure. It's hard to trace it back because it could be a compilation of things affecting their, inflammatory response in their body. It
Yeah,
might be affecting their digestion. I mean, there's so many layers.
yeah.
Would you say that, or what are some of the, I should back up and ask, what are some of the most common autoimmune things that are showing up in your practice that
Well,
you feel might be impacting?
I mean, the basic ones are like thyroid.
Mhm.
Hashimoto's is
Mhm.
really big. But I see a lot of patients who have inflammatory bowel disease, things of that sort. So it's not necessarily one in particular. It's kind of a wide variety.
Yeah. Have you also noticed, Dr. Sachdev, sometimes if they have one condition, sometimes they have several.
Yeah.
Yeah.
But I always say, like, even though one would be like, well, how's my Crohn's disease affecting me from getting pregnant? I just
Mhm.
think if you have an underlying inflammatory disorder, and if it's not as well controlled as it could be, that's going to affect your overall health, including
Sure.
fertility.
Are there things that can be done in terms of protocols to help with that?
Yeah, I mean, there are some anti-inflammatory protocols and things like
Mhm.
that, but I usually will hop on the phone with whoever their doctor is and just try to figure out what dose of medication they're on and how to adjust and how to tweak.
Sure.
That sort.
Right, right. Especially if they have an endocrinologist on board too.
Yeah, or even their GI doctor, like
Mhm.
whoever it is
Mhm.
that they're, yeah.
Yeah, nice. That's really great that you co-treat and just get everyone, on the same page for patients. Are you seeing that those patients that with autoimmune issues have more issues with retreat? I know this is case by case, but I'm just curious, are there more issues with the retrieval process or more the implantation process?
I mean, I think typically the implantation, it's hard to say because I think a lot of times the blame goes to the egg,
Yeah,
right? And the
right.
age. But then when, you have failed transfers, then we start to look at, we start to apply a little bit more blame to the autoimmune
Hmm.
disorders.
Hmm.
So yeah, I
Sure.
would say probably more so on transfers and miscarriages.
Right, right. Especially if a patient's like fairly young, has had a good outcome with embryos.
Yeah,
Mhm.
yeah.
Okay,
Even
that
those are
makes
ones you'd
sense.
expect them to get pregnant. So.
Yeah. Well, so what are some of your favorite cases to treat in your practice?
I mean, I love egg freezing patients because, I feel like there's so much to talk about and so much to do. So that's important. I actually really enjoy caring for same-sex female couples
Hmm.
because I just think that's such a, they have so many options, and it's so wonderful to be like, we have 4 ovaries and 2 uteruses.
Yes, right.
So I mean, I love caring for same-sex female couples, and I do have a special place in my heart for teachers.
Nice. I
Isn't
love
like the
that.
case, but I love caring for teachers, and
Hmm.
I'm seeing that there are a lot more single mothers by choice who are teachers.
Yes, me too. Me too.
So, I would say that combination is probably my favorite, the single mother by choice teacher.
Nice.
And,
Nice.
but yeah, but I love the same-sex female couples because, I like reciprocal IVF. I think that's such a beautiful way to build a family.
Do you find that in those situations of reciprocal IVF, are there any are there any challenges with finding like the sperm donors or how does that whole process work? Because
Yeah.
that's when you're doing reciprocal IVF or if you're a single mom, I mean that's such a big decision.
Yeah. So from sperm donors, the most important thing is that we look at their genetic profile. So patients
Mhm.
will have their own genetic carrier screening done, and then we look at the genetic testing that was done of the sperm donor. But then beyond just what are they positive for, we also have to then match up, okay, are they positive for something that you were actually tested for? And
Sure.
vice versa. Are you
Mhm.
positive for something that they were actually tested for? And if they weren't, it doesn't mean you can't use them, but then we have to talk about what is a risk that they could be a carrier for something, that, et cetera,
Right.
right?
Right.
I think, each person looks at this sperm donors differently. Some will look at it as really important to them. Some will look at it as, hey, this is just part of the process and it's not that important as long as the genetics match up. So each individual or couple is really different. I think for many patients, if they want the opportunity for multiple kids,
Mhm.
many patients will want to have the same donor.
Yeah, that makes sense.
And so identifying, okay, well, how many vials are there? How many am I going to reserve? And then kind of mapping out, all right, especially if we're doing a same-sex female couple, what is our game plan? Is our game plan that we each want to carry, or we each want to, use our eggs? And so I always ask the question to say, okay, for each person, what's important to you? Is it important to you to carry the pregnancy regardless of where the eggs come from? Or is it important to you to use your eggs? Or is it important for you to carry a pregnancy with your own eggs?
Sure. Right.
And I think a lot of people have some sort of idea, but many don't until they have that conversation and then
Hmm.
they start.
They just know that they want to have kids together.
Exactly, yeah, but they have options. And
Yeah.
so again, then we make decisions, at least for the same-sex female couples, okay, based upon sometimes they have a timeline to say, okay, person A is going to go first for X, Y, and Z, or they're older, however they want it to be. But then, we use the clinical data to then kind of guide them to make a decision.
Sure. Yeah. And I'm sure, unfortunately, along the way, as they're going through the process of kind of doing their workup, some things might come up. One might have more optimal egg reserve than the other. And yeah, so
Yeah,
that's
totally. But it also depends, the ovarian reserve is a helpful tool, but it's a number and it's just a number. It's not a true indication of whether you will or you won't get pregnant.
hmm
So when it comes to, certain individuals, many of them have never tried to get pregnant. Right.
right.
And for women
Right.
using donor sperm, they're often using donor sperm because they're either in a position where they're, not in a relationship with somebody with the ability to get pregnant, or because their partner doesn't have sperm, right? And
Right.
so
Right.
they are a blank canvas.
hmm
Many of
hmm
them have never tried to get pregnant. And so it's a possibility that, they could get pregnant quite easily, or it's a possibility that it could be a little bit more challenging.
Yeah.
And so but I think that's a really
Right.
important lens to look through, because you're, an AMH of, a lower AMH in a single mother by choice who's never had the opportunity to try to get pregnant on her own,
hmm
versus that of somebody who's been having unprotected sex, trying to get pregnant, for 2 years is very different.
Right. Yes, that's true. That's a really good point, actually. Well, Dr. Sachdev, I could talk to you forever. I have tons of questions. And I just want to thank you for your time and for sharing your knowledge with all of us and your wisdom. Do you have any upcoming workshops or anything that you wanted to share? We're probably going to be releasing this podcast in like October, beginning of November. So anything coming up in that time frame?
Not that I can think of right now. When we eventually finish our construction, which is again probably looking around this time next year,
Hmm.
we'll definitely have an open house then. But for now, I don't. There's probably not any events in the pipeline. But if there is between now and October, I will definitely let you know.
Okay, sounds great. And I'll make sure to share all of your handles, how to get
Cool.
in touch with you. But before we wrap up, is there any advice that you would give women that are just beginning to explore their path to motherhood? And I should say to couples that are exploring their path to parenthood.
I mean, I think educating yourself, learning, social media or online or books, I think is going to be helpful. Even before you seek a consultation, I think just having a basic understanding or an idea of kind of what's going on, reproductive physiology helps. So
Hmm.
obviously the point of the consult is to learn, right? And to understand. But I always say it's like, by the time I figured it out in college, like that, if I had read a little bit about what I was going to learn about beforehand, I retained so much more in the lecture. And so
Right?
that's what I
Yes.
feel like a fertility
Yeah,
consult is, right? A
totally.
lot of it is a lecture about these complex topics. So if you've at least looked at some information beforehand, it can help you tremendously.
Yeah, and you'll make informed decisions.
Yeah, and it also allows, me and the patient to have a higher level conversation.
That's right. Yeah,
So,
and you mentioned some books. Do you have a specific book that you would recommend?
I mean, there's a lot of great books out there by fertility doctors and things. So, I don't have a specific one, but I mean, even if they just go online and watch Instagram videos, right? Like,
Hmm. hmm
there's a lot of information that they could get. So,
Well, I think they need to just jump on your Instagram because
yeah.
you post some incredible educational
Oh,
tips.
thanks. So,
So,
I mean, yeah, I have a blog that has a lot of information on my
oh, okay,
website,
great. Yeah, that's awesome.
and social media. So, I mean, those are two places that definitely I would go to just to learn a little bit more.
Okay, thank you. Wonderful. Thank you so much, Dr. Sachdev. It was
You're
so,
welcome.
so great chatting with you. I really,
Oh, this is great. Thank you. It was actually like, it didn't even feel like an hour went by.
I know. I was looking at the time and I'm like,
Yeah.
gosh, this is, yeah, it's flown by. And again, best of luck
Thank
to
you.
your new practice and your IVF center.
Thank you.
So
Thank you.
thanks
We'll be
again.
in touch. Totally.
Okay, sounds
Okay.
great.
Bye. Thank you.
Bye.